Well, why don't we get started? We're a little bit behind our time. We knew 20 minutes was not enough for lunch. This is our survivorship half of the presentation. Those of you who've been here before realize this is part, there's actually some science that gets thrown in, but a lot of it is how you live with or after a diagnosis of this. We're going to start off with a nutrition talk right after lunch, which could include a critique of the box lunches. We have Kate Ueland from our nutrition department at the SECA, and she's a dietitian there, and according to Kate, and according to Carrie, who runs the department, a great speaker. So we welcome Kate.
Oh my. Hello. Yeah, no pressure, right? Okay, welcome. I know I only have 30 minutes, and so I want to be mindful of the time so you guys don't have to stay here till midnight tonight. But this talk here, it could go on for days and days and days, right? I can talk about nutrition forever. So I'm going to try to just hit on some of the high points, and then I'm happy to talk individually or about any other kind of bigger questions that you may have. So let's get started. So the objectives of this talk is to look at the role of nutrition in cancer development, and then what foods could we eat to reduce our risk of reoccurrence, since this is kind of the survivorship piece of the talk. And then we're going to look at kind of some how-tos, implement maybe some changes in your diet that you're not currently doing. And we're going to look at one technique. It's called mindful eating. And then we're going to look at what it is and some techniques to practice mindful eating. And then I'm going to wrap up the talk with a couple of different fad diets that seem to be prevalent and pervasive in the world out there. And so kind of just kick us off. So now that treatment's over, your body may be different. And I'm hoping to explore how you can redefine your eating and behavioral patterns to promote wellness and achieve a leaner profile. So let's jump right in. I love this, figure here. So this really explores and describes how important nutrition is in the cancer process, and how micronutrients specifically really play a role in supporting your cell cycle. And so cancer development really happens when the cell cycle goes wrong, and when something in the cell cycle, either genes get turned on, genes get turned off, et cetera, et cetera. And so supporting your body with food becomes really important in supporting your body and making sure that it has the micronutrients and the minerals that are important and involved in promoting a good, healthy cell cycle. And so on the left side of the diagram, these are pro-cancer effects. And so these are things that help to increase the propensity of the cell cycle going wrong. And so things, just to call out a couple of things, obesity, central obesity, metabolic syndrome. So metabolic syndrome is kind of the precursor to diabetes. It's kind of, you don't have a diabetes diagnosis, but you're kind of on the road to a diabetes diagnosis. Eating high amounts of N3,6 polyunsaturated fatty acid's. Insulin, high levels of insulin help to increase cell proliferation. And then, failed, is this a pointer? Yeah. Oh, here, this is better. Okay. So this failed DNA repair, so low folate malnutrition. So, having a diet that would be low in dark leafy greens, for example, or having a diet low in legumes would contribute to potentially failed DNA repair. And so all of these things in combination then increase your risk of developing cancer. And so as you move into survivorship, really trying to increase the amount of micronutrients and minerals that you get in your diet just helps your body in support to reduce your risk of reoccurrence. Okay, so how do we do this? So let's get started. So really the answer lies in a plant-focused diet. And so in many animal and cell studies, nutrients and phytochemicals found in those foods show effects, what I just kind of laid out here in this diagram. They show cell cycle regulation, the process of angiogenesis, so helping to limit or inhibit the process of blood vessel growth to the tumors. Apoptosis, which is programmed cell death, that's one of the things that can get turned off in the cell cycle that can promote cancer development. And then DNA repair, so things like folate. And then inflammation. Inflammation is kind of an underlying theme of my talk, really, is that so many of these disease states are a state of low-grade chronic inflammation. And so that means that this inflammation is low-grade, so it's very minimal, but it's pervasive over decades and decades of time, which just kind of leads to the breakdown of our cellular processes. And so plants help to reduce anti-inflammatory markers in our diet. Or in our bodies, sorry, anti-inflammatory markers in our bodies. And so also the other thing that plants provide us is lots of fiber. And so fiber is the indigestible carbohydrates that are found in a lot of our non-starchy plants. And they're found in all plants. We have two forms of fiber. We have soluble fiber, we have insoluble fiber. They both work in conjunction to lower nutrient absorption, so think about glucose, and they help regulate cholesterol, synthesis, and uptake. So here's my little 2-minute fiber speech. So think about soluble fiber, right, Jell-O, and you put fruit in Jell-O, so fruit would become the carbohydrates, the glucose, and as the gel hardens, well, some of that fruit happens to be on the outside of or like touch the lining of the bowl. Some of the fruit is sequestered in the middle of the Jell-O, and that's really fiber in your small intestine. And so any of the fiber or any of the fruit that's sequestered in the middle of the bowl doesn't get absorbed into your body and just gets pulled out. And the only way that you're going to absorb glucose is if that glucose touches the lining of your small intestine to be absorbed into your body. And so fiber helps to slow the rate and the amount of glucose absorption. And so the insoluble fiber then acts to increase the time, or decrease the time, sorry, that food stays in your small intestine and into your colon, so that you're just like, it kind of acts as a scrub brush along the way, so it kind of cleans your intestinal walls along the way. And that, so if nothing else, and you walk away from this lecture with nothing other than eat more fiber. Okay, so, oh, I'm going backwards, sorry. Okay, so plants are antioxidants, and so you've heard that word, I'm sure, floating all over the world and the internets. But antioxidants, plants have what we call secondary metabolites. These are compounds that the plants make that are not involved in their primary metabolic processes. What that means is that they're not for survival of the plant in a metabolic way. What they do provide the plant is protection. Protection against predators, against environmental changes, so like living in harsh environments or in a place where lots of predators want to eat you. They make these secondary metabolites, toxins, that can fend off predators. And so those have been studied and looked at for human benefit. And there's carotenoids, flavonoids, sulfur compounds, all of these are, they kind of fit in that cell cycle as kind of a backup. So when our bodies don't have that capacity or fail in apoptosis, then some of these secondary metabolites and plant compounds kind of do that work for the body. And so another reason to eat plant foods. So with that, So because plants are so high in these secondary metabolites, all the colors of the rainbow are involved in supporting your body's cell cycle. And so we really promote eating the rainbow of color because they all do and have different benefits. All right, and then plant proteins. Plant proteins provide antioxidants, fiber, vitamins, and minerals. And so this, I hear a lot, this is one area where I hear a lot that people don't eat a lot of legumes in their diet. And so some plant proteins, garbanzo beans, any of your beans, lentils, dried peas, etc., are really good sources of fiber. And they're low calorie and what we would call nutrient dense, right? So nutrient dense versus calorie dense. They provide more nutrition for the amount of calories that you're eating rather than just calories alone with no nutritional value. And so you're just, in essence, you're getting more bang for your buck in that way. Okay, and so the role of omega-3 fatty acids. If you remember back to our cell cycle slide, the N6, the polyunsaturated fatty acids, those diets high in those diets contribute to pro-inflammation in your bodies. And so omega-3 fatty acids actually reduce inflammation in your body and reduce the inflammatory fatty acids that are produced. And the typical American diet is quite low in omega-3 fatty acids, and maybe you can see from this slide why, but eating a lot of dark leafy greens, cold water fish, wild salmon, sardines, mackerel, tuna, bluefish, all are high in the omega-3 fatty acids, walnuts, macadamia nuts, and then soy products, flaxseed, chia, et cetera, all high in the omega-3 fatty acids, and trying to include omega-3 fatty acids into your diet every day. And then nuts and seeds also provide good sources of fiber, good minerals, and micronutrients. Consuming these in moderation is recommended. I know this can become, like, once people are like, oh, I can eat nuts and seeds, and then they just eat an extraordinary amount of nuts and seeds. But be mindful that those do carry a lot of calories because there's a lot of fat in nuts and seeds, but also know that they're plant-based fats, and so they're going to be much healthier for you, but they still carry that extra calorie content. And so we encourage just doing a serving of nuts, so a quarter of a cup is a serving of nuts a couple of times a day. And then soy. Soy is also another pervasive food that has been demonized in terms of its relationship to cancer. Soy is a rich source of isoflavones, which is a category of the phytoestrogens. And so the theory was that for estrogen, or for hormone-positive cancers, melanoma is not in that category. But in terms of survivor and your reoccurrence of risk, like all of these diet and lifestyle changes can incorporate or be beneficial in reducing your risk of developing any secondary cancers. And so phytoestrogens were originally thought to kind of exacerbate or add to the problem of hormone-driven cancers. And time and time again, based on epidemiological studies, so big population-based studies, diet soy actually acts as a protective effect on reducing your risk of developing cancer and also your risk of reoccurrence from certain cancers. And so soy is great. Whole food sources of soy is what we recommend people consume in their diet. So things like edamame, soybeans, tofu, tempeh, miso, those types of soy-based products. And then trying to avoid the soy protein isolates or analogs like fake meats, textured vegetable proteins, because we have less data about that. Okay, flax seeds. So flax seeds are another one. Oops, sorry. Flax seeds are another one that have come under, it's controversial in terms of its relationship to cancer. And so flax seeds contain lignans and alpha-linoleic acid. So flax seeds are a great source of omega-3 fatty acids, and again, research has focused on those hormone-driven cancers and their relationship to cancer, and the research just does not support the correlation between a high flaxseed intake and your increased risk of cancer development. And in fact, there is some, again with soy, there's a protective benefit there. There's great fiber, there's great omega-3 fatty acids, and they're low calorie. And so they're really good to add into your diet, kind of on making a daily regimen of adding flaxseed into your diet. So the recommendation is 1 to 4 tablespoons a day, and provides heart-healthy benefits. And if you're consuming flaxseed oil, we advise you not to cook with it because it degrades really quickly, and just use it to drizzle over your vegetables or use it in salad dressings. Okay, and then this slide is just a reminder that spices and herbs are still plants, right? And they're still providing antioxidant and those phytonutrient benefits. And so they do this through suppression of inflammatory markers. And so you can see my theme, right? Inflammation, reducing inflammation overall in your body. And so cinnamon is a powerful anti-inflammatory and safe to consume in moderation on a daily basis. Garlic, onion, lovely things that you probably cook with all the time, or just, hopefully reminders that you are doing some good things in your diet already that help you reduce your risk of reoccurrence. Okay, and so kind of shifting gears a little bit from plant foods, and we'll revisit that, and we'll look a little bit closer at some ways that you can increase plants into your diet. But for now, we're going to take kind of a step aside, and we're going to look at just limiting your consumption of red meat. And that includes beef, lamb, pork, and the recommendation, according to the American Institute for Cancer Research, is less than or 18 ounces of a week. So that's cooked, and so 3 ounces is about the size of a deck of cards to kind of give you a visual on what that looks like. So you get 6 of those a week, those 6 3-ounce portions. And remember, this is the red meat recommendation. This is not poultry, fish, those other eggs, things like that. Okay, and then just a reminder to stay hydrated. Right? How many of us probably don't drink enough water on a daily basis? You don't have to answer. I'm just, putting that out there. So aiming for at least 8 cups a day. And that is your fluid intake, right? So that's kind of all the amounts of fluids that you're drinking in a day, not just including water. Okay, so that's kind of what foods can I eat to increase or reduce my risk of reoccurrence? Now we're going to look at kind of the how. And I bring mindful eating here today because it really is a good way to practice getting back in touch with your internal hunger and satiety cues. And many of us over time, whether it's a really fast-paced life or just they don't want to think about food. I know lots of people that wish that we could just take a pill and then we wouldn't have to worry about food other than that. And so these techniques really get you to back into your body. And I just find they work really well with people. And so what are the principles of mindful eating? Really allowing yourself to become aware of the positive and nurturing opportunities that are available through making and eating food. And I put this up there because plants are good, and there's lots of really good ways to prepare plant foods. They're not terrible, and it's not this terrible thing that you have to force yourself to eat plants. And I have some cookbooks at the end that I'll recommend that use a lot of herbs and spices to flavor your food so that you can enjoy nutritious food. And respecting your own inner wisdom, really telling, like recognizing that you know what to do. I get people all the time, they're like, I don't know why I'm here, I know what to eat. I'm like, awesome, great, right? So let's talk about what you're doing. And then over time, there's these things that happen where people just don't trust themselves, or they ignore their cues. And so really, like, my job, in essence, is to kind of like reacquaint you with yourself. And, noticing your response to food. What do you like? What do you not like? Without judgment. Right? Like, that's a big piece. Not judging what you're doing. And I have 5 minutes. Woo! And in the end, it's just being able to make peace with food. And so here's some ways that you can increase mindful eating patterns. Try food journaling. And then I'm going to kind of skip through some of these. So this, like making a journal, what you eat, where you eat, when you eat, and then why you eat it. Like, that's the big piece, right? Why? Why are you eating this food? Are you hungry? Are you angry? Are you tired? And then here's some things to do to increase mindful eating patterns. For a week, eat all of your meals at a table. Write that down. Pay attention to how long you chew your food. Chew food thoroughly. Eat with a buddy. Eat with some fun music on, right? Like, make it this wonderful experience instead of like, I'm in front of whatever TV show, just shoveling food into your mouth, right? Even if you're eating the best food on the planet, you can still overconsume. Okay, barriers to mindful eating. We all know what these are. Comfort, right? Like your go-tos. You need to be social. You just had lunch. Everybody's going for ice cream. Well, you are too, but you're not hungry. Right? So you're going to eat it anyways because it's a social thing to do. Bored. How many of us eat out of boredom? How many of us just mindlessly eat in front of a TV? Stress, right? Stress is huge. Okay, and then reconnecting with your hunger and fullness signals. The hunger scale. You should be eating when you're between a 3 and a 6. A 1 is you're starving. A 10 is you're like, you're so full, you feel sick. And then examining your self-talk, listening to yourself. And then I'm going to kind of skip through the weight piece because I really, alcohol, less is better. So moderation, 1 drink a day for women, 2 drinks a day for men. And then organic versus non-organic is a choice. The studies don't show any added nutritional value from eating organic food versus non-organic food. It really is a political and environmental choice. I tell my patients all the time, I would rather see you eating plants that are non-organic than not eating organic plants, right? Or limiting the amount of plants that you're going to eat. If you have a certain amount of organic dollars to spend those dollars on grass-fed beef and your fat-based animal products, yogurt, butter, cheese. Here's some tips for eating a plant-based diet. 2/3 of your plate from plant foods, 25 grams of fiber a day or more. Write down 35 to 50. That's the goal. More fiber. What happens when you eat more fiber? You're eating more plants. It just kind of fixes itself. 3 cups of non-starchy vegetables a day and 1.5 cups of fruit a day. That's kind of our go-to recommendations. And then we've talked kind of how to add healthy foods to your diet. Here's the meal plan. I'm happy to share this with people after because I know we're out of time, but I want to get to some of these fad diets. So the ketogenic diet, right? How many have heard of this? Oh, yeah. So this is a very low carbohydrate diet. The idea behind this is tumors cannot grow in very low carbohydrate environments, right? When we rely on fats to meet our metabolic needs. The problem is that tumors are incredibly smart and they don't care where they're getting their nutrients from. If you pull all the carbohydrates out of your diet, you still have amino acids and you have fats. Both of those macronutrients can be made into glucose via a metabolic pathway in your body that the tumor can still get its nutrient needs met.
Just a little bit with fats. Just a little bit with fats.
Yeah.
5%.
What?
5% of the fat can be turned
but it's still able to meet its needs, and it will divert that, the glycerol backbone, right? Not the fatty acid, but the glycerol backbone. Sorry, in the essence of time, I'm not going into the biochemistry, but I'm happy to talk more about it in more detail outside of this. But the short end of the answer is that based on this hypothesis, this prevalence of sugar feeds cancer is out there in the world. That's not the whole picture. There are many studies that indicate that the tumor is incredibly smart, and if you pull all the sugar out of your diet, the tumor is still going to get its energy needs met using other means. There's two researched areas where the ketogenic diet works: glioblastomas in the brain and epilepsy. Other than that, there's no data that going on a really low carbohydrate diet is going to have any is going to change the prognosis of the cancer. So really the relationship between sugar and cancer is about obesity and insulin versus sugar as fuel for cancer cells. That's where the driving force comes from. It's being obese, it's having type 2 diabetes, it's having hyperinsulinemia. That's where the sugar piece comes in. Okay, the acid-alkaline diet. How many of you have heard of that? Managing your pH, eating to manage your pH. So the thing here, the hypothesis is that tumors cannot grow in an alkaline environment. Absolutely true in a petri dish. Right? That's absolutely true. So in isolation, and this is the problems with these fad diets and these ideas, is that they're in these isolated contexts where you're not taking the rest of the body into consideration. If you changed your pH of your internal body to be alkaline, you would be dead. Right? So why are these so pervasive? Well, the thing about the acid-alkaline diet is that it gets you eating fruits and vegetables. Right? And I'm happy to go into more of the specifics. I know I'm probably out of time, but the end of the story is you cannot change your pH with food. Yes, you can change the pH of your urine, and that's where they get you, because they want you to measure the pH of your urine, and that is not an indicator of your internal pH. Just remember that. The low methionine diet, it's a vegan diet. The hypothesis here is that methionine is an amino acid. Methionine-dependent pathways are disrupted in tumors and can slow growth. There's actually some fairly, it's small, but it's a growing body of studies that indicate that vegan-type diets do help slow tumor growth. Why? Why? Because you're eating plants, right? You're eating plants. Intermittent fasting. The hypothesis here is intermittent fasting can help regulate obesity, type 2 diabetes, cardiovascular diseases, and some types of cancers. This is very new growing body of research. Here they are. Limiting your food to daytime only. In the day with a little fat, right? Helps keep you satiated for your nightly fasting. And then obese microbiota versus lean microbiota. Obese microbiota can actually get more nutrients from what's left over. Bottom line, studies show long-term adherence to restricting any one macronutrient, carbohydrates, fats, proteins, is low, and most of the time people regain the weight, and in some instances gain more than their previous start weight. So, eat food, mostly plants, and not too much.
So we have time for probably 2 to 3 questions, depending on how long.
Thank you very much. You positioned this whole thing as being after treatment. What about on treatment? Is it the same rules, or does it depend on the treatment?
Yes. The caveat, my focus was on survivorship, but like during treatment, it just gets a little bit more complicated, because I really hate to have people focusing on this when they don't feel like eating at all. And so the focus is just a little bit different, like in treatment, and we're trying to mediate against weight loss and malnutrition at that point. But as much as you can adhere to these rules during treatment, before treatment, all of those things, absolutely, yeah. But sometimes people just don't want to eat fruits and vegetables during treatment, and I just don't want them to carry around the guilt, because it really does come down to just maintaining your weight and calories and protein. And so it's just a little bit of a different conversation. But if you're feeling good and things are going really well, then absolutely, the more you can adhere to these, the better. Yeah.
One more last question.
Oh, okay.
I am wondering about cinnamon, Saigon cinnamon. If you don't get Saigon cinnamon, then you can hurt yourself with buying regular cinnamon. I'm confused about, I'd like to incorporate more cinnamon, but I don't know what to get, and yeah.
Okay, yeah. My recommendation would to be buy it in bulk and buy it from a good reputable source, and not buy cinnamon in like the pre-packaged containers in the grocery store, because you're just getting fresher cinnamon. And the different varieties, I'm not very clear on those. But and just overall, like choosing cinnamon that's as fresh as you can possibly get it. Yeah.
Can I ask just one quick question? What's your view on some of these protein drinks or boost drinks? Are they healthy? Can you get good stuff? Because I've been recommended by my oncologist and friends that's a good thing when you're fighting, weight loss and trying to get all the nutrition. So I
Yeah.
just wonder what your view is on
Yeah,
that.
I'm happy to address that individually if you want me to, so that we, in the essence of time.
Go ahead. I think several in the room might want to know the answer to that.
So again, that really depends on where you are in your whole journey. If you're fighting significant weight loss, then I encourage people to just do what they can tolerate. But we always encourage like whole food bases to get your nutrient needs met. And so there's protein powders that we encourage people to use. The Bob's Red Mill Whey Protein Concentrate, the unflavored variety, is what we recommend. But in terms of like Ensure, Boost, there's Orgain that you can get, which is like the organic version of Boost and Ensure. And they are very high in carbohydrates, but I mean, at some point, all of these things trump like you losing weight.
They all seem to have a lot of artificial.
Oh yeah, they have, and yep. And so again, like that's like in treatment, and that's kind of short term. Like the idea is to maintain your weight and to maintain your health. And so having those is not a bad idea if that's like all that you're able to tolerate. If you're able to make smoothies and do like coconut milk and protein powder and good plant fats, make your own Boost or Ensure, and I'm happy to meet with any of you to talk more about that. Then if you're able and capable, then that's like where we would go. But if you're not, it's still better than not eating. Yeah. Yeah.
So I think
Yeah.
the themes I'm also hearing is don't do things that are added stress to you, or you feel like you're being judged, you feel guilty.
Absolutely. Absolutely.
Okay, thank
Yeah.
you so much. That
Yeah.
was great.
Yeah. Thanks.
So let me introduce, we're rushing along a little bit because we want to make sure everybody has enough time. That was great. Our next speaker, Lexi Harlow, is quite passionate about what she does as well. I think she carries a similar passion to Kate. Lexi is a graduate of the University of Puget Sound with a BS in biology and also a doctor of physical therapy at the University of Puget Sound. And she leads our physical therapy group at the SCCA. And she's not just going to talk about physical therapy, but as you're going to hear, rehabilitation after cancer. Great, Lexi.
Thank you, Dr. Byrd. Oh, yeah, sure. So, yes, as Dr. Byrd said, this is a passion of mine. I'm a physical therapist by training, but as you will see in my presentation, rehabilitation is not just about physical therapy. There's a lot more to it to that. But usually the way that people get to rehabilitation is through physical therapy. And so that's sort of the natural fit for it to happen. But I hope through my talk today, I expose you to what's out there in regards to sort of how rehabilitation just as a discipline can really help in a survivorship stage, and frankly, from the time you're diagnosed. Because we do see patients from the time of diagnosis all the way through years after survivorship. So there is a role for rehabilitation throughout the course of a diagnosis of cancer. So why does it matter? So why does rehab matter? As a PT, a lot of people don't think, you work with cancer patients, what does that mean? But actually, if you think about it, it's a very natural fit for the practice of rehabilitation for working with cancer patients. And why is that? By the nature of our work, we're very focused on what's important to patients, what's important to families. When you come to therapy, we talk about what are your goals. It's not about us, it's about you. And we figure out together what your goals are. And that's how we're trained, that's how we practice. We are also practice in a sense of individualizing treatment to your particular needs from the side effects you have had from cancer. And for every person, that's a little bit different. And so we are trained that way, and that's how we practice with patients. And it's really sort of focused on what you need, and everybody's journey is different. A big one, we reduce the symptom burden. We all know there's a lot of symptoms and side effects that come from cancer treatment. What better can we do in rehab than to help lessen those? And we also maintain or restore function. That's the basic premise of what we do, is to keep people active, to keep people mobile, to keep people living life, and to have quality of life. The other thing I'd say is education. So I'm not going to ask people to put their hands up, but how many of you, has your oncologist ever talked to you about how you're doing with function, how you're doing with your day-to-day activities, how are you doing with exercise? Okay? A lot of what I spend my time doing is educating providers and patients, frankly, about the benefits of what rehab can do for them. The other thing is sometimes as a patient, or this is really for providers as well, they don't know what things to look for. They're not rehabilitation specialists like I am to be able to know, wow, that's not a normal function for someone of that age, someone in that kind of condition. And so that's really where it comes into us being able to help screen and identify things that are challenging for people, sometimes that they don't even realize themselves. And then I talked at the beginning about how rehab is not just physical therapy. PT is usually the way that people get to rehab, but there's more to rehab, and I'll talk about that a little bit later. And then there's research more and more coming out that we help to limit the cost of cancer. And the way that we do that is by helping to manage the side effects. And I wholeheartedly believe this to be true. Most of my PT career, I have practiced in oncology almost exclusively, and I will tell you that patients do better when they are in rehab, when they are exercising, when they are active. We will show this to be true. I know there will be more and more literature to come out to show this, but it is a true fact. And the bottom line that goes along with that is it's evidence-based. There is tons of research out there that talks about the benefits of exercise in survivorship, and there is no question that it is, I would argue, the most powerful tool that you have is to be active and to exercise. Okay, so what services do we uniquely provide to the cancer setting in rehabilitation? So we enhance the care of the unique needs of cancer patients. So cancer patients deserve unique rehab needs, and that's really what we provide. Now, when I'm talking about what do you do for patients that have cancer, well, I was trained as a physical therapist just like my colleagues that treat joint replacements. The difference is every day I put my glasses on, literally, but also figuratively in the sense of I look through the lenses of understanding oncology and understanding what a patient has been through, the course of treatment, the prognosis, all of that to come up with a plan of care. And that really is the key. And that's why it's so important that you also work with a therapist or work with a rehabilitation professional that is trained in oncology. And they're few and far between, but we're filled with them at the CCA. And we look through all of our patients with these lenses, and this is really the uniqueness of what we do. And then I would say because of that, we support the oncologist in really managing what's going on with their patients. So many of you have experienced going and telling your oncologist, I'm dealing with A, B, C, D, and E. Rehab is just another way your oncologist can help to deal with those side effects that you're having. And then finally, as I said, it's hard to find therapists who do this. We have them at the SCCA, but this really just provides a great opportunity within the cancer setting if you can say, I have these rehabilitation experts that help my patients get better or go through treatment easier. It makes a difference for who would want to come to the SCCA. That's something I would like. And so it really kind of just elevates the cancer care overall. And then finally, education. I speak a lot. I'm passionate about this topic, but the bottom line is because patients deserve this. There is so much rehab can provide for patients, and so the more we can educate and talk about this, the better. And this is a very exciting time in my profession because actually there is going to be a specialty certification in oncology. I've been waiting my whole entire career for this, but that just is showing the absolute importance of really having a specialty in this area and really finding someone who understands how to work with you in this capacity. And then research, there's lots of opportunity for research. We are actively involved in that at the SCCA. And then program development. We're always working on how do we better meet the needs of patients when it comes to rehab. And I won't go into it today, but we have a number of programs at the SCCA where we're trying to target specific populations. Melanoma, we targeted in one particular way that I will touch on to make sure that the access to rehab happens more cohesively and quicker in our system overall. So when I was preparing my talk, I've treated cancer patients, as I said, my entire career, many melanoma patients, and I will tell you that there's no sort of hard and fast rule about, oh, when I see that melanoma patient on my schedule, I know exactly what they're going to say to me when they come in the door, right? So the bottom line is what I'm trying to say is there's all kinds of side effects that you can experience, okay? This is just a list. This is not all-encompassing, but this is basically identifying those types of side effects that rehabilitation can help with, okay? It's a very robust list, but I would argue that we can make a difference in all aspects of this, and that's why we are so important in the treatment of melanoma. So who can help me? So you probably identified with 1, maybe 2, maybe 3, 4, or 5, I don't know, all of those things. But how do we go about addressing those? So let me talk a little bit about the disciplines within rehabilitation and then how they specifically help in regards to addressing these side effects. So at the top of the list, I don't know, this is sort of a kind of a little known fact I found, but did anybody realize there's actually a whole practice of medicine in rehabilitation? They're called physiatrists, okay? I think their numbers, I have some good colleagues at the Ueland Physiatry. Their numbers are so small compared to when you think about physicians overall, so they're kind of a small but mighty group. Their physiatrists are great because they really are the drivers for setting up a plan of care for rehabilitation, okay? So that's really their role. And then we have physical therapists, which is my training and my background. Then we have occupational therapists, speech-language pathologists, and then rehabilitation psychologists. Now, I would be remiss to say this is not all-encompassing. There are other disciplines that you might think about work in rehab, and they do. But for the sake of my talk today, I'm abbreviating down to the ones that are kind of the big hitters when we're thinking about oncology rehabilitation. Okay, so physiatrists specifically, so they're going to look at nerve, muscle, and bone and treat the injuries or illnesses that affect how you move. Okay, so they're really looking at that from a medical standpoint, from a physician standpoint. How systemically is your body affected by whatever illness, in this case cancer, and how that's affecting you and your ability to carry out your day-to-day activities, be able to move, be able to exercise. And they really treat any disability resulting from that disease or that injury. And they pinpoint the source and design an appropriate rehab treatment plan for that. And that's really the goal and the role of the physiatrist in oncology rehab is to set the plan of care, to identify what disciplines should be involved in that patient's care. So they see patients for initial consultations as well as follow-ups. They do some procedures, okay? And you may recognize some of these. These are often used in other types of joint needs, bone health, those types of things, but they utilize these in the oncology setting as well. They also do EMG testing. Any of you experience neuropathy, okay, or some kind of nerve impairment, they are the ones that can actually do testing to identify exactly what's happening with that nerve, and then they can best direct a treatment plan, because there's all kinds of reasons as to why nerves won't work well, why the neuropathy is happening, the extent of the neuropathy, and so they really can help to identify that. That is beyond the scope of a therapist like myself. And then, of course, medical guidance. Really, the heart of prescription on exercise is done by therapists, is done by PTs like myself, but really there are some certain things that a physiatrist can do, can help us when we're really struggling with somebody's medical condition and being able to help them exercise. So that's really a key role that they play. So physical therapists, which I am one, we really look at sort of, I would say these are the premise, these four things are the premise of what we do. We want to reduce pain, we want to improve and restore mobility, we want to prevent or manage someone's physical condition, and we want to minimize disability, and that's very important to us. We want to make sure someone stays as active and as healthy as possible given the limitations on them physically. So we examine, we diagnose, and we develop an individualized plan of care. And this is why usually PTs are the first line of treatment, if you will, for rehab, because it's pretty obvious to oncologists when somebody's physical status has changed, okay? So they're now falling, they're not able to walk as far, they're fatigued more, so all of those things lead to them coming into the door to us. But as we examine them, we may identify, there's other things going on here that you could benefit from other disciplines. So what are typical PT needs? So these are really the number one things I would say in my practice and our practice at the SCCA that we see. Deconditioning or muscle mass loss. This is a huge one because once you start down the slippery slope, some of you may have experienced this, it continues to go. And so this is a big one that we can help to intervene with. Scar tissue restrictions or fibrosis. This most often happens after surgery. Okay, if you've had a major surgery or some sort of tissue reduction, removal, that leads to scar tissue and tightening, and we can really help with that and help with the side effects that come from that. And then cording, you may have experienced this, axillary web syndrome. PTs have been shown to reverse this quicker than if you just kind of let it do its thing on its own. We can really help with that. And then joint contractures. We really help to sort of maximize the ability of the joints to move in the body. And then fatigue. This is the number one reported cancer complaint, okay, is fatigue. And I would argue there's nothing better than exercise and a well-graded exercise program to help combat fatigue. And then pain. We really are very interested in pain. There's therapists that spend their entire careers treating chronic pain. So we really are experts in helping to manage pain, and we work very closely with our colleagues from the medical side to do that because it is a complex issue. What are some other things? Osteopenia, osteoporosis, so bone thinning, peripheral neuropathies, I already mentioned that, mobility challenges, balance issues. Cancer patients are more at risk, hands down, for falling, okay, just overall. And falls, I will tell you as a PT and spent my career working cancer patients, they never lead to good things, okay? So it's very, very important to us, particularly the SCCA, that we keep our patients upright, okay, and not falling. And so that's something that PTs are very skilled in doing. And then one of the things we do quite a bit of for melanoma patients is actually lymphedema management. And so if any of you have experienced that, you know it well. We also just deal with just peripheral edema. You may have temporary swelling from treatment, that type of thing. We can help to manage that. So what do we do for our treatment? The focus, first and foremost, is patient education. It's all about you when you come to rehab. We want it to matter to you. The goals are yours, okay? We just help you get there. But with that said, we have a priority of making sure that we give you a very balanced exercise or physical activity program. I tend to shy away from my patients or when I'm speaking to say exercise because it's kind of rubs people the wrong way. So if you don't want me to say exercise, you know, we can change it. I these days say physical activity because it just goes over a little bit better. But whatever you want to call it, we have an obligation to make sure that you are exercising and doing all modes of exercise no matter your limitations. So we recommend some type of cardiovascular conditioning no matter what condition you're in, strength training, and then flexibility or balance training, because once again, we want to keep you upright and not falling. And then finally, if you are dealing with swelling issues, edema, or lymphedema, it's very, very important that we manage that because it impacts everything else. And the bottom line is we want you to be as independent as possible. I've told my patients my entire career, I've done my job when you don't come back to see me, and I mean that. You can come back to see me to say hi and let me know how well you're doing. But I have not been successful as a therapist if I have not given you the tools to be independent and be successful, right? So that's really the very important premise of how we treat. And then, of course, pain and fatigue, which I already mentioned. So beyond PT, the next one, occupational therapist. Now, there's a lot of confusion out there about what does PT do, what does OT do, what's the difference, how do you overlap? And there is somewhat of an overlap, but what I would say is occupational therapists are much more focused than PTs on what you have to do in your day-to-day activities or your occupation, your work. Maybe your work is getting up and taking care of yourself and all of that, but that's where the occupation comes from. It's basically what does someone have to do in their day-to-day activities, okay, whatever that might look like. And so occupational therapists really customize kind of their work with a patient on what are the priorities, again, for that person to accomplish during the day, okay? And they, as well, try to prevent or enhance the quality of life when someone is dealing with injury, illness, or disability, and promoting their health as well, just like PTs. Oops. So what are typical OT needs? This is not a comprehensive list, but this is very thorough in the sense of what would be the typical things patients would be referred for. We see fatigue again, so there's overlap there between PTs and OTs. Peripheral neuropathy, particularly of the upper extremity. I would say OTs are oftentimes better skilled to deal with when people are having issues with their hands in particular. So if you're having neuropathy, those numbness, tingling in your hands, we oftentimes will refer them to an OT or really a hand therapist to really work with that because it is a specialty. And then cognitive impairments, unlike PTs, we don't tend to do much with the cognitive side of things, but our OT colleagues do. Lymphedema, we both treat this and we treat it well. Difficulties with the dressing, bathing I was talking about, maybe that is your occupation. That is what you have to do in your daily activities, so they work with you on being able to do that. And then difficulty with maybe chores, shopping, what else do you have to do in life? And then they do a lot with splinting, assistive device, adaptive equipment, home safety evaluations, returning to work. This is a big area of focus, I think, in oncology. Some of you probably experienced this, is you've been through this big deal, this cancer diagnosis that has absorbed your life, and now, you know, you're a survivor and good luck, go back to work. It's not that simple, right? And so OTs can play a really key role in helping to transition and help in that capacity. And then driving evaluations. This is something that's really, really important and something that people want to have for independence. But we need to make sure that people are safe in doing this, particularly when they've had side effects that could impact their ability to drive. So what does treatment encompass? Very similar to PT. I would say a lot more work is done on self-care, really teaching you how to accomplish those tasks that you need to get done day to day. And working with you on what do we need to modify, what do we need to simplify, those types of things. I already talked about hand therapy, and then really the cognitive side of things. So if someone's really dealing with any kind of cognitive changes due to their treatment or just due to age, OT can really help with that as well. Okay, so I would be remiss to say, yes, this is a survivorship talk, and I want to give you tangible, helpful information. But I also want to leave with you that all of these areas noted here have been backed up by science and evidence that therapy and rehabilitation makes a difference for treating these areas, okay? It's very clear, the evidence is there. It's growing all the time. We have played a part and continue to play a part in building this evidence at the SCCA, but I just want to reassure you that from the science side of things, this stuff, rehab, what I'm talking about today, my passion does make a difference. And it really, as you can see with a lot of different things that many cancer patients experience. So it's a lovely marriage between our professions. So I just want to touch briefly on rehabilitation psychology and then speech-language pathology, because they do have a role, probably a little bit less than the other disciplines I talked about. But rehab psych is really beneficial when someone has been really impacted psychologically from an illness or injury. And I really think cancer is one of those things. Most often in rehab, we think about this when someone gets a spinal cord injury or a traumatic brain injury. I mean, something that fundamentally changes their life. Well, I would argue in the course of my career, cancer has fundamentally changed people's lives. And so rehab psych, I think, has a big role. We have a very robust program at the SCCA to really deal with psychological issues, and so we definitely depend and refer to our colleagues in that regard. But there is specialists who actually do this in the rehab world, because people who go through some of these life-altering diagnosis or injuries actually really need that psychological piece as well, and getting OT is just not enough. And then speech-language pathologists, this is really focused on the communication piece, okay? So, and you oftentimes will see the overlap. We're talking about PT-OT overlap. You see an overlap between speech therapy and OT often with the cognitive side of things. And that's just because of the communication piece that the speech-language pathologists are so versed in treating, and that's really kind of their cup of tea. And then also, if there's anything, we see these therapists working with our head and neck populations, or anybody that experiences any kind of difficulties with swallowing or speech and talking, just in this region of the body. Okay? All right, so now I'm going to get a little bit on sort of a rah-rah, this is my plug for please support this venture, make some comments, let SCCA leadership know. So at the SCCA today, we only have PT services, okay? So when I'm talking about physiatry, I'm talking about OT, speech, rehab psych. We actually only have PT on site. Now, I would be remiss to say that if you do come into my department and you need OT, or you need speech, or you need a physiatrist, I depend upon my colleagues at the University of Washington, and that's where I refer them, okay? The problem with that is, you guys may have experienced going to the University of Washington and the back and forth and all of that. So my goal and my mission is to be able to ensure that someday patients will be able to access all of these things at the SCCA on site, right? 5 minutes? Okay. So, but I will say, you can see the list of what my staff, we're small, but we're mighty, what we're able to treat. And so we're able to really get people in the door and connect them to rehab services. And that's really why we are there and why we exist. Someday we'll get there, and I know that will happen. But in the meantime, my job is to make sure that we become the sort of door to the benefits of rehab. So, what do I hope to see in the future? These are the things that I think probably, hopefully you all, by listening to me today, can see the benefits that these could bring to people who have been in your shoes, as well as those to come after you. So ADL training, hand therapy, vestibular rehab, this is when you have vertigo. This is a specialty as well. Speech and swallowing, returning to work, cognitive, group exercise and therapy, survivorship, and then integrative care. Massage, acupuncture, these are the things that people are looking for, and I get consulted on all the time. So I'm going to leave you, and then we'll have some time for questions, a few questions. This is actually a quote from Dr. Julie Silver. She's a physiatrist from Harvard, And she actually is one of the most prominent physiatrists in our field in oncology. And she basically is stating here the benefits of exercise. And so you probably heard me allude to this earlier in my presentation. But I wholeheartedly believe, and this is probably why I'm so passionate about it, is that if we could harness the power of exercise in a pill, and I know researchers who in this area who say this, because if they could just do it, which is, we'll never be able to do it. But the point is, if you could harness the power of exercise in a pill, it would be the most powerful drug that exists. Okay? That is true when you look at it scientifically. Now, we will never be able to do that. So what's the second best thing we can do? We can help people to be able to maximize what they can do for exercise and physical activity. And that really is the most important takeaway I can give you today, is utilize rehabilitation to get you moving, to get you exercising. Because there is no more powerful thing as a survivor than doing that. Okay? So I will just end. These are my kids. My daughter, these are a little outdated. My daughter is 5 now. This is my son. He's 1 now. He was a little bit younger. But I have to say, this is actually an example of thriving in survivorship. My husband is a survivor. He was diagnosed with testicular cancer actually the week I started at the SCCA 11 years ago. I'm happy to say he's doing well. Obviously, we have 2 children. So I have my own survivor in my home, and he hears me, yeah, to him all the time about exercise. But he's my hero. He exercises more than I do, so I don't have anything that I don't need to tell him.
Okay, folks, if you could take a seat, we're going to get started.
Hi.
So I think we got most people back in the room after that quick break, and we are almost on time here, which is surprising at this point of day in this conference, as those of you who come before know. The good news is we're not going to shortchange people. The other good news, remember I started the day off with the good news and the bad news. The bad news was that I didn't have any patient stories. I have literally had 5 people from this room come up and talk to me. And I'm in the spot where I'm actually having to ask a couple of them not to speak this year, which is the opposite of what I was concerned about, as my wife, and my wife is in the back here, can tell you, was my concern about this conference is I didn't have the patients. So we're going to cut them a lot of slack, as we talked about, but I want to make sure we do have time for those stories. As you'll hear from our next speaker, storytelling is what many of us think is really the essence of life and community. So with that, let me introduce our next speaker. So this is Donna Oiland. Donna was recommended to me by one of my patients and one of our attendees, and probably one of next year's speakers who couldn't be here today, who had attended a Cancer Lifeline workshop, a multi-day workshop where Donna was a speaker. And she can speak on a variety of topics and can certainly fend for herself in terms of her credentials and what she does and what her passion is. I wanted to mention, before she started speaking as a speaker of life, would that be a fair statement?
That's fair.
She was the iBank director at UW for 25 years and involved in organ donations. So that's a very sensitive area of life and work, and it takes some special people to do that. So I just wanted to make sure that you knew that was what came before her speaking life. Donna, we're delighted to have you here. And there's a handout in your packet that Donna has provided. I'm sure she'll cover part of that.
Yeah, it's not a follow-along thing, but I am so honored to be with you. And as I was thinking about this time with you, it's amazing that you have gathered here today and that you are sharing your experiences, and I think it's so important. Getting here today, I am first of all, I don't have a PowerPoint. I'm a technophobia. I don't know if it's a word, but I'm sure that it is a word. And I don't have a cell phone. I just am. I know. Thank you. Thank you. Thank you. I am convinced that we no longer live in community. We live in proximity of one another. And I retired from Evergreen Hospital 4 years ago, and one day I was in the restroom resting, and the lady next to me said, "How are you?" And I thought, well, isn't that nice? And I said, "Fine." And then she said, "What are you doing?" And I thought, she's not talking to me. She would know what I was doing. And then really quietly she said, "I'm in the library and I have to be really quiet." So I flushed the toilet. You know, there is a problem here. There is a problem with this stuff. Even just coming down here today, I was glad. I'm going to speak about advanced care planning, and I was glad I had my living will all done, because the person behind me who was upset that I was actually doing the speed limit and was not pleased with the fact that he couldn't get around me, I was sure that he was going to knock me off the road. So I'm happy to be here. I am a storyteller, and I am passionate about talking about getting our lives in order. And I took care of my husband for 8 months when he was on hospice. He had colon cancer. It was 20 years ago last Friday, on June 2nd. And he did everything he could do to prepare us for when he wasn't going to be with us. He was 50 years old. You know, he wasn't all that. I thought he was spiffy, but he wasn't all that brave when like when he sprained his ankle, it was worse than childbirth. You know, if he got the flu, it was nobody had been that sick. And I truly believe that one day he had his teeth cleaned and he had to miss work for complications because of that. But when he knew that his life was limited, he began to prepare for the time when he wouldn't be with us any longer. And it made all the difference in the world to us. He wrote us letters. He made a notebook. He told me not to sell the house and buy a bed and breakfast. I mean, he did everything he could. And we reaped the benefits of that work. And it has really become my passion to encourage other people to think about how they live their lives. And if we know we're not going to live forever, how does that change how we live? And I think that it makes a huge difference. My daughter died 17 years ago, and she had a little boy, and he has been my teacher. And he's now 20 years old, and one day, several years ago, we had a big snowstorm. I think it was in 2007. Remember when it snowed a whole bunch and then it rained and then they closed I-5 down by Chehalis. Anyway, he made a snowman out on the back on our deck. It was beautiful. It had a husky scarf and a top hat, and he was so proud, about 6 feet tall. And we took a picture of it, and I said, you know, it's going to rain tomorrow. And the weatherman said that there's no chance that it's not going to rain and your snowman is going to go away. And we went to bed, and when I got up in the morning, I looked out and there was the snowman, but he had gotten up in the middle of the night and put an umbrella over the top of the snowman to protect the snowman. And it really, I thought about that, and I thought about my husband's colon cancer. He ate broccoli and Brussels sprouts and cauliflower, and he still got colon cancer. And you know, we try to do everything we can to avoid things happening, but we still end up facing crisis. And I believe that crisis is a terrible opportunity to waste. I believe that we learn from crisis. If you think about California and their drought, they learned so much in the process of going through that, the fact that they didn't have water. They've changed a lot of things because of that crisis. I don't think they have the drought anymore, but we do learn from crisis. And I invite you to think about the journey that we're all on, and when are those times that we really learn things. And so I just wanted to, I put down something. I do love storytelling. I don't know, have your stories turned out the way you thought when you were growing up and you heard the fairy tales once upon a time, and then how do they always end? Happily ever after. I don't know, my story didn't turn out that way. The only thing that I can relate to is the 3 little pigs where they talk about the hair on your chinny chin chin. I can now relate to that. That's the only thing that I can really relate to. So we have the opportunity to really have some control over how we are going to live our lives, and if we were not able to speak for ourselves, who we would want to do that, and having conversations that we would want to have if we were not able to speak for ourselves. So in our country, there has been something passed called the Self-Determination Act. And the Self-Determination Act says you can make choices about what treatment you would or wouldn't want if there came a point in your life where you couldn't speak for yourself. Now, when would it be that you couldn't speak for yourself? Under what circumstances would you not be able to talk for yourself? A coma. So where would you, what about, anyone else have any ideas? A stroke?
If you're dead.
If you're, well, thank you. Why didn't I think of that? Perfect. A stroke. What about, the guy behind me today could have bumped me off the road and I could have been in a car accident. My kids don't think I drive that well, but I say there is no longer a speed limit. It's a speed suggestion. Don't you think that? Nobody does. There is no limit. You can just go however fast you want. It's true. That's good. That's good, but there's no limit? Oh, no, okay. Okay. All right. I was going to watch out because I slap. Okay, no. So a couple of years ago, there was in the news, there was a lot of headlines and stories about a woman named Terry Schiavo. Do you remember that? And she had had a cardiac arrest, and she had not received oxygen to her brain, so she was anoxic, but she was still having some. It appeared to her parents that she could still communicate. Her husband believed and said that she had told him that she didn't want to live the way she was, and her parents didn't agree with that. And that family dynamic played out all over the United States and even went to the President of the United States. I don't want that. I don't want that. And I don't think anyone else wants that. But we have the opportunity to make some decisions about how we are going to live our lives and how we are, and how if we couldn't speak for ourselves, what we would want. But I want to focus a lot on how do you make decisions about this process, and how do we look at who we are and what do we value, and how do we use the crisis to make how we live differently, choose how we live differently. And I have brought with me, and I've given you a handout that talks about this. It's a values statement. There is something called an ethical will, or a values statement. An ethical will, actually, there is a Jewish name for this. It's a Jewish tradition that started 3,000 years ago. I do not know Hebrew, so I'm not going to attempt to say this, but it used to be that people took the time to really stop and think about what was important to them, and they included it with their legal will, or with however they did it 3,000 years ago. And more recently, there was a man named Randy Pausch, who was a professor at Carnegie Mellon University, who had to retire early because of a health issue. And as at that university, when somebody's going to retire, they give a last lecture. And Randy Pausch, he was 40 years old, and he chose to give a last lecture, and the lecture was to a group of people, but it was really for his children, that's who he was talking to. And from that lecture, they created a book called The Last Lecture, and it was on the New York Times bestseller list for several years. And I am here to encourage you to think about your last lecture. What would you want? What do you value? And how do you make choices about how you're going to spend your day, spend your money? Do we really think about that right now? In our society, that's part of the reason of this technical thing that I'm against. There's so many things going on. I feel like so many people are in like a hamster running on a wheel. I feel like that's how people live their lives. And I really believe we need to slow down. I just want to point out there are 1 million apps. How could that possibly be? How could you possibly have 1 million apps? There is an app. You can buy an app so that you don't get information about Kim Kardashian. And Kim Kardashian is making money from the app so people won't get information about her. My brother travels the world. My brother is with a World Relief Organization, and he travels around the world, and he has an app that I believe is the only app that you really need, and its initials are WTP, which means where to pee. So any place in the world, he knows where the closest public restroom is. Now that makes sense to me, but I can't figure out so you can get apps to make things go faster. You can get, how could there be a million apps? But it's part of, I think it's part of what clouds our brains. We don't communicate. Have you gone into a doctor's office? And it used to be that people sat and shared their stories and their experiences. Now, what are people doing? They're on their cell phones. I know. You're waiting in line at the airport. Nobody gets bored anymore. Everybody is on their cell phones. And I'm just, okay, that's all I'm going to say. I don't judge you for having a cell phone. It's great. And I know that some people have to have them. I wore a pager for 25 years when I was at the iBank. I wore a pager. So that's the old-fashioned way of getting a hold of people. But everything seems that everything has to be bigger and faster and more. And sometime I think we need to step back and just say, what is really important to me? What do I really care about? And how do I define a good day? If I were to ask you that, how would you define a good day?
If you smile.
If you smile, well, that's a good day. Yeah, thanks. Anyone else?
A day at my cabin.
A day at your cabin? Aha. Can we go? We're coming. Yes.
A wonderful visit with somebody.
With somebody, and it's just somebody you care about. Somebody.
Walking my dog in Lincoln Park.
Ah, walking her dog in Lincoln Park. Huh? Meeting a new person? A new person or a new activity? Anyone else? Huh?
Sharing music with others.
Sharing. Are you a musician?
I am.
Oh,
The other day I was playing the piano at Skagit College in the lobby, and I heard a voice behind me when I finished the Moonlight Sonata, and he said, "Oh, that is exactly what I need."
oh. You know, music to me, I'm envious. In the shower, I am fabulous. But that is the extent of it.
In the hospital, my husband corrected me.
Oh, but thank you. My favorite piece of piano music is Claire de Lune, and it sends me. Oh, that is great. That is great.
And he's a pastor, and so he asked me just last week if I would play for his worship service at his church.
Perfect.
So tomorrow I'm going to be.
Perfect. That's great. Yay. So next year you need to have a piano in here. So, okay, take care of that. Anyone else? Yes.
A good diagnosis.
A good diagnosis. Wow. Wow. Thank you. You know, I have 6 grandsons, and truly all I have to do is sit and watch them. I mean, to me, that is, well, not the old ones. I mean, you know, they're but the little guys. I just that to me is, I'm happy. I'm happy. I don't need a cell phone. I don't need anything else but that. But you know, it really, when you think about it, all of the things that we just talked about really cost very little or nothing. They'd have nothing to do with technology. They're very pretty simple things that we can be intentional about doing for the most part. And that, to me, is the sad part of this whole mentality that we live in, because it is so focused on the pursuit of happiness. The pursuit of happiness instead of the pursuit of meaning. So if you were, I'm a mom and a grandmother, and I like to have the last word. And so, because I'm right. Because I'm right. So before I even considered doing my advanced directives, I decided I needed to figure out what I really valued, what was really important to me, and how would that affect how I decided the care I would or wouldn't want if I couldn't speak for myself, and how I would choose care that I might receive, even if I could speak for myself. To me, that looking for those values first was the most important thing. And I think that hopefully, maybe I can encourage you to start thinking about this as well. So the last lecture idea, I have given you a handout that is in your folder, and it's how to write an ethical will. Some people think that that's a little bit, and I don't know, it sounds like, how am I going to do that? But the information that I've given you, I believe you can do this. And I really encourage you to start thinking about it. And as you start to think about it, it really will create opportunities to talk to people who you are close to. So I am not trust me, I loved it when I was more shallow, but I'm now, things have changed. So, but I created this, this document, and I'm just going to share part of it with you. I love inspirational sayings. My kids say, in my house, they're always telling me that they always use the term BS in our house. It means bumper sticker. So when I tell them, change your underwear, you don't know what's going to happen. They say bumpers, if you're a bumper sticker. That's what they're going to put on my headstone when I die. She was a bumper sticker. So that's what I've used for my ethical will. And I've written it as a letter. So I'm only going to read part of this to you, but I want you to see how this isn't a big deal to do. You can do this. And I believe with this information, just answering the questions, however you choose to do that, you could do this. So I started it out by saying, dear precious ones, there's a popular book entitled Everything I Needed to Know I Learned in Kindergarten. I know from the experiences from the last few years of my life that life lessons that really matter can't come from kindergarten lessons, but only from experiences that nurture our growth and grow our compassion. What I want you to know for all time. So to me, that's the essence. This is what I want them to know. When I'm not here anymore, my voice is still going to be there because I'm getting the last word in. So I have, some of my things are, I've learned to be kinder than necessary because everyone we meet is fighting some kind of battle. Every miracle starts with an impossibility. I've learned that the richest people are not those that have the most, but those that need the least. I've learned the biggest mistake you can make is to always be right. I've learned that I can't choose how I feel, but I can choose what I do about it. I've learned that a smile is the best way to improve my appearance. And my ending to this is, I want you to remember that my happiness is not your responsibility. That's a really important part. I'm not going to read all of that, but it says, I love you all so much. I'm so proud of the people you are, and I'm so grateful to have been given the gift of being your mother and grandmother. I want you to always be there for one another. Nothing except your relationship with God is more important. It doesn't matter what kind of car you drive, or the house you live in, or the brand of your jeans, or where you take your vacations, or how much money you have in the bank. In the end, all that matters is love. Leave your hands open to give, and they'll be open to receive. If you're reading this, it's because I'm no longer physically with you, but you know exactly where I am. I will always be with you. All you have to do is remember. Please remember what Dad told us before he died. He said, never not do something because I'm not there. Please be happy, laugh, pray, work hard, pay your bills, tell people you love that you love them, and stay connected. I'll see you in a little while. I know, thank you. But it's not rocket science, but it is what I want them to know for all time. It doesn't mean that I don't say this to them all the time, but it is attached to my legal will and my living will, as well as I have talked to them about it, because I think it's important for them, because we have these conversations. Can you do this? Yes, you can. Will you do this? Yes, we will. Okay, thank you. Good. I feel a lot better about that. So one of the things that things that you're going to, that you consider and hopefully do is completing an advanced care plan, which would include talking about treatment that you would or wouldn't want under certain circumstances, and naming a person who would speak for you if you couldn't speak for yourself. And that is very, very important. It is having these conversations, I think, opens the opportunity to talk about things that we wouldn't usually talk about. I don't know, why is it so hard to talk about end-of-life stuff? Scary? I want you to think about something. There is one thing in your life that you know is going to happen to you. One thing, only one thing. After you're born, you don't even know, nobody knows if you'll walk or talk. They don't know if you'll go to school. They don't know if, you don't know if you'll drive a car or go to college or what your career is or if you'll get married or if you'll have children. You don't know any of that stuff for sure. There's only one thing you know. And yet it is the one thing that we don't talk about. And I think that that's just wrong. I think that that's wrong. But I also think that there's a real benefit to opening these conversations. And there are lots of online resources to do this. There are things called, there's the Conversation Project. And in our state, we have an initiative right now where the Washington State Hospital Association and the Washington State Medical Association have come together to work to get more people to do advanced care planning so that when the circumstance comes up that they may not be able to speak for yourself. It doesn't happen very often when that happens. But if somebody comes into the emergency room and they are not responsive, there's questions about how they should be treated. If somebody can talk to them, tell people in that situation what they would want or not want, they can legally direct what treatment they receive. And I want you to think about this. Even if you went into the emergency room, let's say today the guy behind me hit me. You know, I didn't really like him. I didn't like him. The flashing the lights, this flipping me off was one thing, but flashing the lights was not that. Anyway, but so if I had gone into the emergency room and had an accident and went into the emergency room and had no documentation and nobody knew anything, somebody's going to make a decision about what care I want. What care I'm going to get. And it might not be what I wanted. So if you don't have this, in those circumstances, you really do have one. Somebody's going to decide for you. And you have the opportunity to decide for yourself what care you would want or not want under certain circumstances. So there are a number of documents that you can use. You know, when Monica, the person I met through Cancer Lifeline, we did this for 5 hours, 2.5 hours on 2 days. And so I have 45 minutes. So I have to talk really, really fast. Anyway, but I do want to just tell you that there are documents that you can get to work on this project. And some of them, does Cancer Lifeline have an advanced care document? But we will find out. Yes, we will. Swedish Hospital, can I say that? Oh, perfect. Okay, well, will you type Honoring Choices Pacific Northwest? Honoring Choices Pacific Northwest. If you just Google it, I do have a computer, and I Google. We're as one. Google and I are as one.
I think she's saying
Honoring Choices. Honoring Choices.
Apparently I'm deaf today.
That's okay.
There we go.
We can get you a support group. No, there's this Honoring Choices Pacific Northwest is the collaboration between the Washington State Hospital Association and the Washington State Medical Association. And I would encourage, there are documents on that link, but I would just want to tell you that there's a story about my husband there, and there's a picture of him holding my little grandson. He was born 1 week before before Dave died. And, oh, did you get there? Oh, go to personal stories. I wasn't planning on that one.
I just figured I'd grab it while you were.
Good job. Okay, so do Understanding Love. Do you see Understanding Love? There's I know. Isn't that, it's a really sweet story. It's too long to read, but let me give you the essence of it. My son was in high school. He was a senior in high school, and Dave wanted to see him graduate, and he didn't see him graduate. But Andrew was on his way to the United States Air Force Academy. And Andrew and I had gone to Colorado Springs, and he brought home boots that he needed to break in before he went to be a cadet. And Dave sat and polished those boots for the last 6 weeks of his life. Every day he spit on those boots and polished those boots. And it was an amazing thing for Andrew to go off on this adventure, carrying a symbol of love that nobody else could ever understand. But there's more to, I'm sorry, I didn't plan to talk about that. But, oh well, we just go with the flow. But that website is really helpful. There is also, the Conversation Project, you talked that, okay, there are other things, like there's an organization here in Seattle called Death Over Dinner. How does that sound to you? Does that sound fun? You know what? It's actually pretty cool. There's a guy named Michael Heeb, and he has created this plan for people to gather to just have conversation about this topic. And he is now in Australia, and the whole country of Australia has taken this on as a project for is it a country or a continent? It's both, right? So the whole continent of Australia, because one of their leaders was out running and had a heart attack, and he was taken into the emergency room unconscious, and he didn't have anybody, he had never talked to his family about this, and he did survive, but he said, we have to get this conversation started. So they have gotten Michael Heeb to go down to Australia, and they are having these events where people gather, and they will bring up topics about anything that, it's supposed to be organic, you're just supposed to talk about it. Maybe you're sharing your stories of your own experience of loss in your life or whatever. So Death Over Dinner is one of the, did you put that up there? Oh, good. How are you doing that?
She's good.
Wow. I am so impressed. Anymore, nobody ever says, I wonder. Everybody, you ask a question, and what do people say? Google it. Yeah, that's true. So no, you never wonder about anything anymore. You Google it. Okay, so another one is a death cafe. Okay, that makes me feel better. Okay, and there's these groups of people in Shoreline on the first Monday of the month at the Shoreline Library at 7 o'clock. People gather and they just have conversations. It's not scary. Some people come in a crisis and they're sharing. It's not a support group, it's a conversation. But beginning to think about your plan gives you the opportunity to have these conversations. And I believe that these conversations are really important. They can open lines of intimacy that you would never have any other time. I never knew so many things about my husband until the end of his life. And the idea is, to me, we are all living on borrowed time. We don't know. We don't know. I have to go back out onto that freeway again to get home today. I don't know how that's going to go. But because I know that there is an end to my life, how does that change how I choose to live my life? How do I change what I focus on and what I do? I am honored to be able to share a passion that the lessons that my husband taught me while he was preparing for the end of his life. And so it is a passion to encourage people to start to think about it, but it's hard. There are other documents. Did you put 5 wishes? Okay, thank you. I want you to know that you can also write your own, you can write out just a document. And I have some samples of how people have just said, talking to the people that they would want to speak for them, the person they would want to speak for them, they sharing who they are and what's important. I want to read one of these to you. This is really good. It says, "My dear loved ones, I trust you completely to make decisions regarding my medical treatment in the event I cannot participate in the deliberations myself. I ask you to give consideration to the quality of life, not only for myself, but whether I would be of meaningful value to my family. For me, life may still have value even if my mind is not present. If my grandchildren or great-grandchildren would have the opportunity to have met me and I am not overly burdensome to care for. I do not mind being in a nursing home as long as I am pleasantly disposed and you indeed would bring the children to visit. However, I do not want to be kept alive if I become angry, belligerent, or demented, and the only memory the grandchildren or great-grandchildren would have would be negative. Additionally, please remember life can be pleasurable for me as long as I can watch sports on television and play solitaire. However, if I cannot recognize the teams that are playing, begin to cheat at solitaire, or God forbid, begin to think soccer is football, please do not treat any illness I get." Pretty simple, but he makes his point pretty clear, doesn't he? So, I mean, you can do this. There are ways that you can do this. There are this project, Honoring Choices project, that the Medical Association is doing right now is there are, like Swedish Hospital in Edmonds, I'm a facilitator, and people can arrange to sit down with someone and help them fill out an advanced care plan. You can do it one-on-one, or better, 2-on-1, if you have the person you would want to speak for you there with you, because you are having that conversation. So how would you choose somebody to speak for you? You know, in this document, most documents give you a place to choose one person, the main person, and then if that person wasn't available, a couple of other people. Sometimes I'll speak to a group and somebody will say, I have 5 children and they just love each other. And they get along all the time, and I'm going to name all 5 of them as my spokesperson. Yeah, thank you. First, no, do not do that. My experience I'm a hospice volunteer. My experience at hospice is that this situation brings out the very best in families or the very worst in families. And I'm the receptionist usually on Saturdays, but I chose to be here with you today at an inpatient center. And sometimes there are restraining orders against family members coming into the hospice center. Please this is your opportunity to change relationships and to encourage conversation and to ask for forgiveness and receive forgiveness and tell people how you feel about them. You need to choose one person and you need to talk to them. If you don't talk to them, they are not going to know anything about what would be important to you. So you have to have the conversation. Does that make sense? You could even not have a document as long as you've talked to people. You got to talk to them, okay? Do you have any questions about that? I have 2 friends. Their names are Jill and Lindy. They're sisters, 5 years apart. Their mom raised them as a single mom, and they just were so close, best friends. 3 years ago in June, well, before that, their mom had asked Jill to be her her durable power of attorney for healthcare if she wasn't able to speak for herself. 3 years ago in June, there came a point when she was in the hospital, and Jill said she doesn't want any more treatment. We've come to the end, and now she doesn't want any more treatment. And they stopped the treatment, and she died. Their mom had never talked to Lindy about this. So Lindy now believes that Jill killed their mom. And they are no longer best friends. They have not spoken for 3 years. So you have to talk to the other people on the list as well. You need to help people understand why you've chosen one person. My children are not going to be they're not going to be my decision makers. For one thing, my son is an Air Force pilot, and he just goes flying off, so he's not even responsible. So he might not even be here. My daughter gets hysterical if I go to the doctor. So she's not. So I've chosen my best friend, who is a retired nurse, and I've known her. Our parents were friends before we were born, so I've known her for 70 years, and she knows me well. So, and we've had the conversations. But I've talked to my kids, and they know why I chose Jan. They know why they have not been named the #1 person. Does that make sense? Do you have any questions about that? Do not make two people. Don't make two people your decision maker. Don't do it. And it will give you in your documents. It will help you give you information about who you should or shouldn't choose. You know, this is a huge topic, but I want to leave you with a thought, and that is a story about. It's a true story. Years ago in India, a group of people decided they were going to build a golf course. I don't know anything about golf. Little round ball, hit it in a hole. I mean, that's it. They were going to make the best golf course in the world, and they hired wonderful landscape people and architects, and they built this great golf course. And the first time somebody went onto the course to try it out of the woods came a monkey, and it grabbed the ball and ran with it. This was not something that they had planned on. And what they found was every time they hit a ball, a monkey came out of the woods and grabbed the ball and ran with it. I mean, and they had put a lot of time and expense into this. So somebody said, let's build a wall around the golf course. Okay, so I didn't believe that at first, but now, you know, because of there's somebody who thinks we can build a wall along this. Anyway, do you think the wall helped? No. So then they decided they were going to round up all the monkeys and take them away, move them to a different place. Do you think that worked? No. So outside of the clubhouse, they had a list of 10 rules, and at some point someone said, what are we going to do? What are we going to do about this? And they made an 11th rule, and the 11th rule was hit the ball where the monkey drops it. So I want you to think about that. You know, our lives, it's sort of a life lesson. We don't know, all of these things happen that we don't plan for. And we think that we've got it figured out, and then something else happens. And to me, that, you know, I think that hit the ball where the monkey drops it is a good philosophy of life, if you know what I'm talking about. I thank you for letting me be here with you today. I wonder, do you have any questions? No?
About 5 minutes for questions before this starts. Feel free.
Tell us another story.
Yes.
I actually have 2 endorsements to what you just said.
Yes.
One is that when my father died, he went into a coma suddenly. There was no warning. He had left. When my father died a few years ago, he left my mother responsible for that end-of-life decision. And the thing that was so important about it was that my sisters, I have 5 sisters, they were divided on whether we should stop feeding Dad. And so one person having that vote and having it down on paper stopped the argument. And that was huge, because it could have been horrible, as you said. It could be just horrible. The second thing is, I think this audience here represents a perfect place for you to be saying this, because all of us have had that monkey dropping the ball in a new place at some time in our recent or not so recent past. For me, it's very recent, so I am very much, I can remember very clearly when I had been sort of led to believe that I had 20 years of life expectancy, and now I'm told that, oh, maybe 5, maybe 6, maybe 7. But wow, I just became awake to the fact that this really is going to happen to me. And so it changes the whole paradigm by which you view the rest of your life. And so I think that being told again that this is something important is really, and I hope, I'm sure everybody here appreciates at different levels of intensity, just how important it is what you're saying.
It's so important. I want to thank you so much. Thank you for sharing your own story as well. Do you remember Kathy Gertzen? Yes. Kathy Gertzen. We all know Kathy Gertzen. We watched her live with a brain tumor for years, and she kept on keeping on. But at one point, towards the end of her life, this is what she wrote: "There is only one way to take life now, and that is one day at a time." It's funny, when you stop planning and try to decide what you're going to do next, how each day becomes more and more beautiful. It reminds me that somehow we have to slow down and we have to start realizing what is really important to us and who are those people that we want them to know how we feel, and how often we miss the opportunities to have those conversations because everybody's running in so many different directions. So I thank you so much for letting me be with you.
Thank you, Donna.
Well, Donna, that was spectacular. Thank you so much. And we didn't need any slides for that, right? This was a conversation going on, and I think the interaction you heard from the audience, as I told you before you spoke, you're speaking to an audience, and there are 6 people in the elevator, and no one is speaking to anyone, and we are 2 feet apart. And everyone's doing this. Even when they come on or leave, there is no acknowledgement of who is there. And I don't see that trend going the correct direction or a more positive direction. So one way to keep it going is storytelling. So the volunteers who approached me earlier may feel a little daunted coming after Donna Oiland, but it's not about the performance of a professional coming in and really bringing things to clarity. It's about speaking from the heart. So we have 3 volunteers who said this, said they'll come up. As I approach people to talk about their stories in the last few months, I had a conversation with someone who would be willing to share a story, but there were hard parts of the story that were very painful. And they thought they might not leave the message in the room that they wanted to leave in the room. And I just wanted to take a second talking about the importance of the hard parts of the stories. And many of you in this room have had hard parts, and you're in them now, or you're looking at them. And we try to have stories that have an uplifting end to them, because part of that is bringing hope in a spot that sometimes you have trouble seeing that. But I just want to, after that conversation with that patient, it just made me realize we need to acknowledge the hardness of what is happening now or has happened, and it's okay. Now, do we want all the stories to be just about hardness or about things that happen badly and it's a soapbox? Not necessarily, but we need to acknowledge that those are there. So I wanted to just bring that topic up, which I think is important. And I'll give you just a quick story from me, because I told you I had some stuff prepared since I didn't think anybody else was going to be up here, that doesn't have anything to do with melanoma, but this has to do with seizing life each day. And when I was a medical student, there was a professor at Tulane in New Orleans named Earl Peacock. Vern may have heard of Earl Peacock. He was a very famous plastic surgeon. His son was also Peacock, and he was in my class. We had 6 birds in my class. I was Byrd. There's Peacock, Hawk, Parrot, Swan, and there was another one I'm forgetting. But Earl Peacock was a very controversial figure, and he one of his lectures, he had the third-year medical student class, and the topic was hand injuries. It was a plastic surgeon. He came in, and he wrote up on the board 5 references. And he said, if you read these, this is all you need to know about hand injuries. Now, we've got 55 minutes. How do you want to use me? And, we're used to spoon-fed medical students. The seal, throw the fish. Don't make me think. Give me the fish. And everybody sat there quietly. Then some sucker raised his hand and said, Dr. Peacock, how do you feel about fingertip injuries? And I thought it was a fair question. And he looked at him and he said, well, first of all, how I feel about anything shouldn't make any difference to you. I think what you're trying to ask, and he rephrased his question and took it a completely different level than this guy had in mind. It was a little intimidating. We walked out of that room, and 3/4 of my colleagues were shaking their heads thinking, what a jerk this guy is. And I'm thinking, my hands are sweaty, and I want to go to the library. And I thought, I'm going to be around this guy. So I hung around as much as I could, this professor, and he had open office time at 5 p.m. every Thursday. And anybody could come in that office and talk about anything. And I just thought one day, I'm just going to go in there. And so I sat down, and a couple other crazy people were in there as well. And I would walk out every time humbled, usually a little intimidated, usually a little feeling of complete inadequacy, but I always had sweaty palms and wanted to go to the library. So after I got comfortable with that for about 6 months, I said, Dr. Peacock, you seem like you were always just seizing life, and how do you do this? And he didn't even hesitate. He said, frequent collisions. And I didn't quite that, because I was thinking a physical collision where you were crushed or injured, like the guy behind you on the freeway. And he wasn't talking about that. He was talking about getting yourself into situations or recognizing situations where it takes you off balance or has you think differently. And that, to me, just completely resonated. So I'll give you an example of one of those. About 6 months ago, I was walking out of University of Washington Medical Center after a long day, and there's a walkway that goes to the S1 parking garage, and there was a man in front of me moving very slowly like this, pushing an oxygen canister. His pace and my pace were very different. I was going to get home to my wife, Cindy, and this guy was going like this. And as I started to cruise past him, I just stopped. And I just decided to pace him a little bit, and I said, oh, and he looked at me like, what are you talking to me for? And I said, well, I just noticed that you're coming out of the hospital through the parking garage, and most patients don't come out here. And he goes, oh, no, I'm a volunteer. And I said, well, where do you volunteer? He said, well, I volunteer in the surgical ICU. And I said, well, great, thank you for doing it. Thank you for being a volunteer. I'm a huge volunteer fan. And I said, why did you choose to do that? He goes, well, I'm facing a lung transplant in about a year or two, and I want to see everything through this experience. And we talked for 30 seconds, maybe 45, and I walked that way, and he walked that way, and I thought, I almost missed that collision because I didn't stop. So I wanted to bring it up because these are facing all of us every day, including the driver behind you, and maybe a real one that way. But I just mentioned that story because I found that incredibly enriching when I choose to recognize the opportunity for these collisions, and you have to be open and mindful to the opportunity, and they're everywhere. So that's a little story I was going to tell you. Now, I'm going to go in order of how people need to leave today. John, I know you've got a ferry to catch. So John Troxell came up and said, I am would like to tell my story, probably because I needed somebody to tell the story and you're taking pity on me. But John, why don't you come up and spend about 10 minutes or so sharing your story, and it's not about the competition with Donna Oiland. You want to use this? Or
I don't care.
Okay.
Yeah, clip it on.
Yeah, flip it on. Can I just put it in the pocket?
There's a clip.
Let's just kind of do this.